To start this afternoon, we're going to discuss how Erdheim-Chester disease impacts a very important real estate in our body, which is our brain and also our eyes. It impacts it in different ways. We have seen MRIs where there's a vast infiltration of disease, but there is little to no signs and symptoms in the patients, and in other patients we see nothing, and there's a lot of neurocognitive and neural problems. So for that, we will have Dr. Eli Diamond to speak to us about Erdheim-Chester disease, the brain and the eye. Dr. Diamond is a neuro-oncologist, and he's an active researcher and clinician for this ECD care center at Sloan Kettering. He's also under the Department of Neurology and Early Drug Development Service. So, welcome.
Hi, everyone. I'm sorry that my travel drama led to schedule reshuffling. I appreciate the accommodation, and I'm very pleased to be here. Thanks. So I'm going to talk about how ECD, quote-unquote, lesions and not lesions affect the brain and the eyes, more about the brain. I hope to convey that ECD really causes a wide spectrum of neurologic issues, regardless of what's seen on MRI. I'll just show a little bit about eye manifestations of ECD, and then sort of share a bit about how I think about treating ECD in the brain. So, if you ask ECD patients, as I do in my registry study where patients report their symptoms, 3/4 of ECD patients report neurologic symptoms of one kind or another. And they are, when I say not always, I would say often, frequently not explained by scans. And if you look hard enough, about half of patients with ECD have some abnormality in structures of the eye, and even if they are not symptomatic. And then just want to make the point that BRAF and MEK inhibitors can affect the eye as well, and I'll talk about that for a moment. So these are like the typical sort of most kind of flashing neon lights ECD abnormalities in the brain. These are in the lower part of the brain, in either what's called the brainstem or the cerebellum. And this is the most sort of common site when ECD is going to affect the actual substance of the brain itself. And so these are what I would call the classic ECD brain symptoms, which is a decrease in the speed and the clarity of speech, imbalance, usually because of difficulty stabilizing the trunk and the legs. Often the coordination of the structures in the midline are affected earlier and more severely than sort of, further out in the body. But in other cases, or more severe cases, there can be impaired coordination of the arms and the legs, sometimes weakness of the arms and the legs, sometimes that coordination that is required for swallowing, all of the things that happen from your tongue to your throat all the way down, there can be issues, there can be impairments there, issues with swallowing, and then that back part of the brain, even though I just talked about balance and motor control, can actually be involved in mood and behavior and thinking. So there can be at least two different kinds of effects of ECD or ECD in the back of the brain on mood. One can be what appears to be a mood problem, which is kind of like a easy laughter and crying, sort of inappropriate laughing or laughing out of proportion to how something seems funny, or what seems like being very moved emotionally by something that is not very sad, like the cute puppy or the sentimental picture. And this is the kind of thing that is probably more bothersome to the people around the affected person because they think someone is very sad. They may not actually feel as sad as they seem. And then also there can be, this can happen. Also, there can be some other types of effects where maybe there's a little bit of kind of like the brakes on what may be appropriate things to say can be lifted. And so there can be some maybe slight inappropriate comments, behavior. So there can be a mix of these things. And I think that kind of bringing these things to awareness is probably the most helpful, and helping everyone to have a bit of a sort of a sense of humor and acceptance about it. ECD can affect other parts of the brain As has been said before, one common manifestation is the stalk of the pituitary, where a bunch of hormones are made, and the lack of this hormone that regulates water can cause this condition called diabetes insipidus, or what's now called AVP deficiency. There can also be a lowering of other types of hormones, such as the sex hormones leading to reproductive function and others. This here is ECD sort of lining the coating of the brain, or the meninges, which can cause various types of symptoms if they get large. And then this is ECD kind of in various areas of the brain. You know, can ECD affect here, there, everywhere? The answer is yes, but these other things would be, I would say, fairly uncommon. But, you know, I think what I want to emphasize is that there's a whole array of experiences that people have, which I think either are neurologic or feel neurologic, that, you know, are pretty much not necessarily explained by anything you're going to see on a scan. So fatigue, you know, you could talk about whether that's neurologic or not, but that's a profoundly bothersome symptom. And then, you know, anxiety and depression and mood problems are, you know, extremely common. A study that we just did showed that 1/3 of patients have either anxiety or depression, and 1 in 7, it's moderate or severe. And depression, of all the different histiocytic disorders, depression is most common in ECD and is associated, it's more common in people who have neurologic involvement of their disease, and I feel like that's probably the least surprising to the people in this room. Cognitive problems are extremely common and are under-recognized, and I think what people feel is like a brain fog, difficulty paying attention, trouble with remembering things, and then particularly difficulty with multitasking. This can affect the ability to work, and we've also observed in our group that ability to work is definitely impaired when there's neurologic involvement of disease. And then just to emphasize again, this can happen with people with absolutely pristinely normal MRIs. And as I said before, these types of symptoms are the most commonly reported of all in the you know, hundreds of patients that I follow who complete surveys from time to time. This is an old study that we did, which was comparing the MRI scans of quote unquote normal MRIs of ECD patients to healthy individuals of the same age, you know, off the street, healthy, normal MRIs. And this color here is areas of the brain in ECD patients that are actually somewhat a little bit thinner with loss of the brain tissue as compared to normal. So this looks very dramatic, and the actual amount of volume is small, but this is more for me to show you that there is more than meets the eye, and I think that the patients know that better than anyone. There have been other studies like this since that time suggesting that, you know, submerged somehow within a normal MRI, there is some process happening that I think the patients are feeling. So this is just a couple examples of the fact that ECD and histiocytosis can affect really all different parts of the eye. This is the eyelids, the sort of very famous xanthelasmas. This is behind the eye. This is all in the front part of the eye, what's called the episclera, here in the front. And then this is the back of the eye around the retina, where you can have sort of little pieces of ECD, which may not be appreciated elsewhere. And this is where there's some sort of effect of the nerve. And these slides are courtesy of my colleague, Dr. Jasmine Francis. And when I send a patient to her, let's say they have Langerhans, she will call me and say, Eli, you're going to find ECD also, I can tell from looking in the back of their eyes. So I think that the eye is, we always say the eye is the window to the brain, but for ECD, I think the eye is the window to the body as well sometimes. So in terms of treating ECD in the brain, you know, there are what we call the conventional therapies, which is sort of the stuff before targeted therapies, you know, before the BRAF and MEK inhibitors. And, you know, I would say it's not that these had no favorable outcome. It was more my experience that it was a bit unpredictable. I think there probably was the most data for interferon alpha, which I think you guys heard about a bit this morning. Giving that in high doses can help the brain to a degree. You know, I had one patient who benefited from interferon alpha in the brain. Anakinra is blocks inflammation in the body. So there are examples of all of these things helping the brain, but there's probably lots of examples where they didn't, which did not, make it into the literature. So I would say that these have a role in certain cases, but how well they're going to work, I would say, is unpredictable. So in terms of the targeted treatments, this is just a couple examples of ECD in the brain treated. This is with a BRAF inhibitor, and as you can see, the white stuff is gone. A very, very nice response by scan and in the bones as well. But one of the challenges of these treatments is if you, in many instances, I think especially with ECD and especially with BRAF mutation and especially in the brain, if you stop these treatments, then the disease comes back. So it kind of acts like like the dial on the stove that you sort of turn the flame up and down. So this is just one patient who was treated with vemurafenib. You can see these white dots get smaller, and then he had to stop vemurafenib. These come back, goes on a different BRAF inhibitor. They're suppressed. And then similar for someone else who had to stop treatment for one reason or another. And then, one solution which I think works for some people is, well, then don't stop it, just use a low dose, sort of sail through on a low dose. And I think that there's many people for whom that works, but not for everyone. You can see this sort of white around here. This was a patient that I had, and I've seen this on several instances, someone who is on a very low dose of treatment and starts to have very, very slow issues with speech and balance. And this isn't, in my opinion, this isn't like the ECD figuring out a way around the vemurafenib. This is just probably not enough of that drug getting into the brain, and the ECD just sort of smoldering and declaring itself very, very slowly. So, I would say in terms of the current state with the treatments that exist, there are many people who just do great on the treatments that exist. Probably they tolerate them well, they have very dramatic improvements, and they last for a long time, which is, wonderful. There are some people who I think have partial improvement, and I think the question that we don't necessarily know is the partial improvement because, quote unquote, the damage is done, so you can't grow that brain back, or is the drug maybe not getting to the brain, or is it maybe some combination of the two? And as I said, the upshot is that there can be just a very, very slow worsening over time that I think is not always apparent to the patient or to family members, but then they see us, and it's been 6 months, and it's like, wow, what's going on? You sound different than you did, or you're walking different than you did 6 months or a year ago. To mention just the eye effects of BRAF and MEK inhibitors, there's an important role of the ophthalmologist. Anyone on these treatments who has visual symptoms, they go straight to the eye doctor. The BRAF inhibitors cause this entity called uveitis, which is an inflammation of the part of the eye. It's often manageable with drops. The MEK inhibitors can cause issues with the back of the eye called the retina. Fluid can collect and build up in the retina, or it can swell. There is this very, very rare complication of the MEK inhibitors where there's a blood clot in the back of the eye. It's extremely rare, probably about 1 in 300 people who take the MEK inhibitors, and it's generally at a high dose. But I think the punchline is that almost all of these eye issues, if identified, can be managed without having to stop the treatment entirely. So, what can we do? So I don't think anyone knows what's best, because I don't think what's best for one person is best for everyone else. Some people do great on low dosing. For some people, where the low dosing just seems to lead to this kind of creep, then I will do high dosing, but on and off. Take a week on, take a week off, a few days on, a few days off, to try and like land a punch in the brain, and then you give the body a break to try to reduce the side effects. Our colleagues in Italy just showed a benefit of what we call treatment holidays, which is taking breaks. They observed this in a very systematic way, and it's really trial and error for every patient. Just trying to be patient, change the drug, change the administration, maybe try a week on, week off. Maybe if you get your rash at day 5, do it 3 days on, 3 days off. So it's a lot of trial and error and just trying to tweak things to get as best you can. So I'm just going to show 2 new concepts that we have worked on, not because I think they are the answer for everyone, but just to illustrate that there are other ideas out there that are being implemented. So we have given chemotherapy into the arteries that supply the tumor. So this is not pills, it's not through the IV, it's like the way someone gets a stent to their heart, except it's giving chemotherapy behind the eye or into the brain. This is I always say this is our sexiest treatment plan, where we treated someone's eye and behind the face and in the side. So this is very complicated, but this is an example of sort of what I showed in the beginning of ECD in the brainstem that was treated with those chemotherapy infusions. And what's nice is you can see there was a very clear, measurable resolution of double vision, which is just terrific. This is someone else who had a tumor behind her eye, and then this is pretty much a blackout of her visual field. You can see that her eyes are bulging, and got these injections with, basically return to normal vision and a loss of all that mass effect behind the eye. And then one other option that has been explored is there are, for the BRAF and the MEK inhibitors, there's a new generation of these drugs that the chemical has been tweaked a bit to fit into the brain better. And so I think there's a new era of these. This is a new brain-penetrant MEK inhibitor called mirdametinib, which I've given to some patients, and this is all neurologic disease that got worse despite the available treatments that then had improvement when you add this brain-penetrant version. And this is just different ways of showing how we try to measure functional improvement in people even when there's nothing to find on a scan. So this is a scale of balance, sort of scale of speech and balance. And so for people getting this brain-penetrant drug, you can see that in some individuals, their scores of speech and balance get better, lower is better. And then we had one just incredible outcome of a young woman who, this is called counting fingers, so one woman who pretty much had lost vision in both eyes with a return to vision, and then this is an improvement in her hearing. So, ECD involving the brain and the eye can be, it's very difficult, and there's some more obvious manifestations and less obvious manifestations, and I hope I've conveyed that there's a lot more than scans show. I think that all these factors conspire of delayed diagnosis, very lasting symptoms, kind of side effects of treatment, poor energy, struggle with mood, and I think that these all can be very difficult for people's experience of the quality of their life, and we really wish we could break this cycle. The current treatments absolutely have a benefit that are limited in some cases, and we certainly need both more effective treatments and earlier diagnosis. And my ophthalmologist colleague would have me remind you that the eye is the window to everything. And I'm on time, so there we go.